The Foundation is interested in closing health disparities. This population has a particularly acute set of disparities that it faces, and those disparities have to be addressed as a part of any broader agenda to close health gaps in Connecticut and in our nation. The role that African American male health disparities can play in closing those gaps is really critical, because it's a driver of the wide gaps that we see. So if we can make headway on closing gaps among African American males, we have promise for closing gaps among other racial ethnic groups as well. From the interviews I've been conducting with stakeholders across the state in neighborhoods like Bridgeport and New Haven and here in Hartford, what we've been learning is that there are community leaders already addressing the health needs and health disparities faced by African American males. Most of them are working with adult males. We also know, though, that there's limited capacity among those organizations doing this work. They tend to be smaller organizations, they tend to be faith-based groups, they tend to be community-based organizations. Some are affiliated with universities. That gives them a little bit of additional capacity to meet the needs of this population. There are research projects underway, which is an exciting endeavor as well. But this issue of capacity of the organizations doing the work is really critical, and related to that is the scant resources that they have to support their work. And I think the third and final takeaway is that we really need important system reform in order to make sure the population of men we're talking about have minimal health care coverage. And at the moment, particularly for older men, that's not the case. I think the systems change approach to improving the patient-provider relationship for African American men really is twofold. The first is better integrating Medicaid within the existing systems that touch men's lives. For example, we know that large numbers of low-income African American men are fathers in this state. Those men, many of them are in the state's child support system because they have a child for whom they're obligated to pay support. There is an opportunity to integrate Medicaid within child support so that when a father's order is established, the caseworker for that child support order asks a father about his employment, which the court is already a matter of the court's interest, and also about his health care coverage. The rationale here being that a healthy dad is a dad who's a much more competent dad. He's able to interact with his child in a healthier way, and he's also able to work more consistently and therefore meet his financial obligation to his kid. That's one example. There are other examples where these men's lives touch public systems, and if our public systems were better integrated, we could ensure that the men who don't have coverage in this state are actually getting the coverage they need. The second component of systems change really calls for better educating the medical establishment to the needs and sensitivities of this population. We know from research that many African American men prefer providers who look like them. In the absence of that, they desire a provider to whom they can relate. That's an understandable preference, and in order for that to be realized, we need providers who are better trained and much more sensitive to the cultural norms that African American men present in care. We don't necessarily need to have physicians of color to treat African American males. We do need, though, physicians who understand culture and understand context and understand the social and economic determinants of African American male health disparities and can relate competently to African American men around the health needs they present.